that brings me to the next discussion of this steering committee today, which is about measurement of quality of life and use of PROs. Well, mainly in chronic GvHD, but of course, guys, please don't hesitate to jump in if you would like also to allude to acute GvHD, because obviously quality of life is a matter of concern, irrespective of the type of GvHD you're having. Next. So this is exactly, I don't think we need to convince this audience about the profound impact on quality of life of both acute and chronic GvHD. This is about morbidity, but also mortality. And when it comes to chronic GvHD, actually, this can persist for years. It has an impact on the functional status, the social status, the financial actually impact is huge. Employment, daily living, truly these patients, and I keep on repeating the same thing because I heard it from many patients. The patients are very grateful they have been cured from whatever leukemia, but they are now facing and struggling with a new disease and complication. So, and the problem is even more complex because, especially again for chronic GvHD, we can have multiple organ systems being involved. So the disease is very heterogeneous. Obviously, chronic GvHD has little to do in terms of functional impact with dry mouth acute GvHD or with fibrotic lesions. And this is why, beside all the established scientific and trying to be objective criteria, like the ones developed by the NIH, and again, we should commend and praise all colleagues who worked on these NIH criteria, because this has been a turning point which actually allowed to improve the quality of research in this field. We need to pay attention to PROs and quality of life. Next. So we do have a few examples about PROs used in GvHD. I will not go through all of these questionnaires and well-established PROs. But clearly, I think the Stephanie Lee symptom scale is well established, the NIH scale. There are, of course, the ERTC, the SF36, and so on, PROs used in GvHD. Next. So Lee symptom scale, I think this is probably the most popular, most famous one. Very straightforward, relatively quick. I've rarely seen patient complaining about it, while patient can complain about other questionnaires which are felt to be very complex, very intrusive. This one has 7 subscales. It is actually both used in clinical trials, but also I know many colleagues using it in routine practice. It is actually quite mature since 2002, and it is now more and more used in clinical trials, especially as secondary endpoint. Of course, it may not be able to capture the dynamic process of the symptoms unless you are able to do it every day, maybe, or every other day, which is, of course, quite difficult. Next. So in real life, and as it is expected, guys, whenever you have a new drug being approved in a space, whatever disease, well, it allows to rejuvenate research. And you will see more and more important research. And this is exactly what happened when it comes to PROs. We've seen more and more studies putting PROs on the podium. For instance, belumosudil, which is approved in the US, in Canada, in the UK, in China, and many other countries for the treatment of advanced or steroid refractory chronic GvHD. It's a ROCK2 inhibitor. Actually, we can see that this least symptom score has been used very nicely in the different studies, including in real-world data to assess fibrotic manifestations. And this is crucial because we know that one of the key mechanisms of action of belumosudil is being able to target both the inflammatory but also the fibrotic component of the chronic GvHD phenomenon, which I believe is a key step. So this is why the results, the conclusions from following the modified least symptom score were, in my opinion, very useful and very important when it comes to bringing and to showing, to demonstrate how useful is this drug in the patient. Okay, so again, I'd like to open the floor, first of all, asking this panel of experts, how do you measure quality of life and whether you use routinely PROs in your practice? How can we improve this? Because obviously people are trying to do their best in their environment with all the constraints, but the question is, can we do better and how to do it? And what is your feeling about specifically the use of this least symptom scale as it has been done in previous studies like the one I showed with belumosudil? So I'll stop here, and now maybe, I don't know, who is going to be the first volunteer? I can see Professor Savani, yes.
So, unless patient, so we do fill out NIH GvHD form, grading severity. We do have an interval history where we write the quality of life measure, but we don't have separate form to do the PRO or quality of life measure separately unless patient is on a clinical trial. So no, it's not separately measure quality of life in clinical practice unless patient is on a clinical trial.
Same here, unfortunately, even though I think we all recognize that if we had an easy mechanism to do this on a weekly or monthly or quarterly basis for all of our patients, it would be a treasure trove of data.
Good afternoon. So same for us. Actually, we measure quality of life by routine questioning, but we don't have a formal patient-reported outcome outside clinical trial. So we assess the patient at the clinic. We report the complaint. We report the handicaps, if any, the vision and the eye and being the skin, all the organs involved and how they affect the patient quality of life. But we don't have a formal PRO assessment.
Thank you, Ali. Andrew?
I think one of the things, so, the least symptom scale is not validated in pediatrics. So In pediatric trials, I think that it's at this point not the most appropriate tool for measuring quality of life. There are a couple pediatric quality of life scales that can be used. There's a pediatric promise scale that can be used, things like that. So I can speak more to the pediatric side than to the adult side, but I think that the Lee symptom scale is quick and easy for use, and we did a slightly modified and abridged version in a telehealth program or project that we had performed between our adult and pediatric GvHD clinics. So I think that there really, in pediatrics, there needs to be a more focused look at what is the most appropriate quality of life questionnaire to be used in different age groups. Obviously it's going to be parent reported in our very young patients, but then we have our school age children where you probably want both pediatric, the patient and the parent providing comments on quality of life. And then in our older adolescents, certainly they can be, filling this out by themselves. So I think that that's one major area that has been really understudied in pediatrics.
Thank you. Nico, what is the current practice in your center? And for instance, you reported earlier about this combination of, for instance, ECP and Ruxo. Were you able to look into some of these PROs in addition to the response rate, treatment-free survival, and so on?
No, but I think I completely agree to all my colleagues is that I don't know how we can implement that on a daily basis, but I think this is so important and such a no-brainer, in my opinion, that we should try to harmonize, and especially harmonize collecting it, that we all have the same database. We can assess what other factors are also affecting quality of life, not only treatment, maybe also socioeconomic status, etc. I think this is also very important. And I think we all should try to make an effort to do that. Therefore, I really think this session here is so important, because this is, again, as I said, in clinical reality, completely not implemented. And I think that's really, really unfortunate.
Thank you. No, and I appreciate your candor, because we go everywhere and we claim PROs, quality of life, are extremely important. We have to work on them, and actually now asking honestly the expert who is doing what, and everybody is telling us, well, unfortunately, I'm not doing it on a routine practice. So there is a sort of a gap between the theory, the ideal word, and the word as it is. So one question, is this issue of feasibility or non-feasibility of the quality of life measurement and maybe PROs is something because of, I don't know, time constraint by the physicians, and maybe we should involve other healthcare professionals in this assessment? Because at the end of the day, we can always try to live in the ideal world, but there is only 24 hours in a day. And if you have to spend like 2 or 3 hours just doing a single patient, I know Dr. Wolf will tell me, oh, it doesn't take hours, it takes only minutes. I've been debating this. But Bipin, you have a very nice, strong, robust program looking into long-term evaluation, where actually it's not only about the GvHD doctors, but also you have a wide variety of healthcare professionals who are involved. And still, it doesn't look like you are able to do it systematically to everybody.
Correct. It is very difficult unless someone is going to pay for those half an hour, 1 hour of quality of life assessment. Support staffs are there, but who will bill? How they will bill? This is how program works. So
I would argue that a programmatic investment in a dozen iPads that directly feed the data to a REDCap database is not the biggest investment one could make. It's not necessarily at the top of anyone's list, but I don't think you need a human asking the questions. I think you hand the patient an iPad, and that's that.
But Corey, is it just about handing the iPad? My feeling was that the most difficult part is actually the interpretation and the analysis of all of these data. It's not just about handing the questionnaire and ticking boxes. You're wrong.
Yeah, no, I mean, I think the interpretation is can be relatively straightforward in a clinical scenario. We all understand that an improvement in 5 to 7 points is considered clinically meaningful. That's the measure that's used in all the clinical trials. And so even if all you got was a number that you could track from clinic visit to clinic visit, that might be sufficient. I don't think any of us are going to look at the subscores and that is not for real-time use, I don't think. But if you got handed a number every 6 or 8 weeks from your patient, I think it's a piece of data you could use in real time.
So, Corey, this is what you do? You have all patients with iPad?
Absolutely not.
Okay.
I'm telling you what would be optimal case scenario. We do nothing like this at our place.
Andrew, I see you open your mic.
Actually, I don't have anything to add for this one. My mic was already open.
Oh, okay, sorry. So let me ask a question, another question to the group, which I don't know whether there's a right or wrong answer to this actually. Assuming we have a new drug now in chronic GvHD, and this new drug is actually bringing a sort of a relatively minor improvement compared in terms of overall response or whatever well-established objective criteria. But then, surprisingly, you have very positive PROs. What one should think about this potential new drug? It's a hypothetical scenario. It doesn't exist. I have nothing specific in mind. And don't think exclusively about regulatory approval, just from a medical standpoint.
Yeah,
Does it make sense to have something which is useful for PROs and not necessarily translate into CR? Because again, in chronic GvHD, things can be very difficult, because once lesions are well established,
right,
it is unrealistic to think that suddenly things will come back, like if the patient was like 20-year-old and everything was nice and beautiful and well. Nico, what do you think?
That was thank you for highlighting that. I think that's exactly the point. Probably you know that better as me, is that there are patients that have, I think, maybe only PR and will never achieve CR, especially like, for instance, sclerotic skin patients that may completely benefit from a study standpoint where we can evaluate how they actually improve their function, what can be done, how they are limited by that PR, or if they even okay with that. And so I think we need refined factors as well that are relevant to patients that maybe we as physicians cannot even come up with right now because we are not affected by that disease. And as you said from the beginning, I think there should be an involvement of all stakeholders, nurses, family members as well, that maybe can evaluate what debilitating factors these patients actually have. I think this is really relevant to maybe open this view not only from a medical but also from a societal standpoint for these patients.
Excellent. Ali, yes.
Yes, there is a point that we need also to address, which is the interpatient variability in reporting quality of life. So there are patients that are more resilient than others, and for the same symptoms and the same level of disease, some patients will, in our own experience, I think this is not only cultural in the Middle East, but maybe also present in other societies, the same you will have an important interpatient variability in how their life is affected by the symptoms they have, particularly if the chronic GvHD is, as Nico mentioned, is in partial response and the leukemia is in complete response.
No, I agree with you, Ali. I think this is well taken, and I would even add something which I have noticed in a few patients, even several patients, is that the same questionnaire of quality of life can appear very bad at some point, especially in the beginning. And progressively, and although the treatment wasn't miraculous, still the quality of life starts to be like improving. It looks like, you know, patients get used to it. They have put themselves in a totally a new era. It always reminds me of someone who had a car accident, lost his legs, and, you know, you have frustration, you have anger, and then progressively you adapt to the new situation. So I don't know if you colleagues have a similar experience with patient. While our treatments were not, you know, magic, still they have started accepting and improving. Bipin?
You know, this quality of life score is same like, you know, we do TSS 50 in myelofibrosis. We don't do TSS 50 unless patient is on a clinical trial. It's same thing, MF, SAF questionnaire. So there should be something different. This GvHD quality of life score measurement is not possible in current way in all patients like you guys do in Europe. In US, I don't think, unless patient on a clinical trial, there is not impossible, I would say. Corey suggested iPad, but we can't give iPad to everybody.
And I think that, you know, we've all seen patients that we started on a new agent where they're feeling better and there's absolutely zero objective response whatsoever. For those patients, I hold on to hope that we will see some response with time, although we may never, you know, really hit really a meaningful response. So I think that to the patient, there is certainly added value, but it's hard to parse out what is the placebo effect versus what is an actual unmeasurable response to this drug or intangible response to this drug. And I think that's one of the things that's really hard to get to in our patients, especially when there's deep set fibrosis or long-sitting fibrosis in our patients.
Thank you. They're very thoughtful comment. But if I want to be the devil advocate, I would say, you know, for a given patient, as long as he or she is improving, actually, they don't care about our science and our evidence base. They say, oh, doc, I'm feeling better. And that's the most important part of the story. This is really a very exciting, fascinating discussion. I don't believe it's going to be easy to solve because it goes from cultural issues, time limitations, variability among patient, variability across ages, obviously quality of life of someone who is 70, 75, not very active is going to be totally different from someone who is still professionally very active and so on. But I think it's already a great step that more and more, like in this forum, we hear people advocating and speaking and bringing PROs and quality of life into the discussion. And I believe the next step is that, and this is, I think, our role as physicians and healthcare professionals, to lobby to integrate more and more of these PROs as part of the assessment of drugs. It's not only about survival, it's not only about living long, but it's about living long and well. And I believe everybody hopefully would agree with me on this. So I'll close this discussion, which was very important.